issues. Okay, maybe I'll give that question. Thank you so much, Benjamin. Um, Today we have a very interesting webinar, which is about getting solutions to our problems, or put it another way, how you can turn problems into opportunities by doing technological innovations. Um, My name is Peter Waiswa, and I'm the chairperson of Sogas Forum. Today's presenters, we have two presenters. One of them is a friend of mine called Sane. Sane is an American, from India, who is a staff at the Johns Hopkins University at the School of Biomedical Engineering. But for some of you, in Busoga, he has been deeper in Busoga than many of you, because he's been working a lot in Mayuge, and I think recently was in Bugweri and Iganga, tracking mosquitoes. As biomedical engineers, they try to find solutions to common problems. So one of the innovations is going to be talking about is called VectorCam. VectorCam is an app that actually tells you about the sex of the mosquito and the type of mosquito and the medical characteristics of a mosquito in just 20 seconds. He's one of the co-founders of this innovation, and Sun is joined by Marina Rincon, who is also a staff to the Global Health Program, is the Global Health Program Director at the Center for Biomedical Engineering, Innovation and Design at the Johns Hopkins University. So she's an engineer, but focusing on medical solutions. Sana is also a good friend of mine and many of us. She's been working in Uganda for the last 4 years. Sana is also one of the co-founders of VectorCam. So they are going to be making a presentation on what are the experiences by medical engineers working with health workers, come up with solutions. As I said, one of the solutions is an app that is now being used to identify and track mosquitoes. But there is also another innovation whereby we are actually working together, I must say, not doing alone. They are working with me for the last, their center has been working with me for the last 10 years, with my colleagues, with some of our members, like Justin Kauda. And they have another innovation. We have another innovation, which is being used to see whether we can do diagnosis of cancer of the breast using AI. What is the role of AI in diagnosis? But all this work is actually happening here in Uganda. So I thought they should present, and then we see and learn how we can turn some of our problems into opportunities. Sane, I don't know who of you is making the first presentation. I think together, if you could each take about 20 minutes, then we can have the last minutes as Q&A. So either Sane or Marina, you can put up your slide and start.
And I think I'm gonna go first. Let's go and put up the slides. Let's see. Present. You should be able to see my screen.
Not yet.
About now. And let's start sharing. Present. There you go. What about now?
Yeah, I can see it. So it's good to go.
Perfect.
Thank you.
So, good afternoon, everybody. I am actually located in Baltimore, where our Center of Bioengineering is and innovation. And it is really sad that I am not in Uganda because usually August is when we do all our field trips. But due to I have become a mom, really, 4 months ago, I became a mom. And I always say that I became a mom thanks to the Ugandans. So I couldn't go this time. I am Marina. I am the Global Health Program Director of CIVIT. CIVIT is our bioengineering and innovation design program. Is a master program where our students, and I will explain a little bit today what our students do, how many projects we have been involved with in Uganda with the Makerere University and also Dr. Weisba, and a little bit how do we teach to the students the innovation process and what makes a little bit different about our innovation project process to others. As Dr. Weiss was said, I have a background in engineering as well, but a long time ago now, about more than 10 years ago, I was a clinician. I was a physical therapist, and myself from Spain, which is where I was born and raised. Which when I found myself in a situation as a professional that I couldn't solve some of the problems that my patients had or some of the needs, I transfer my clinical skills to more on a innovation mindset and how we could solve those problems. And after a long journey of creating my own startup, being in the industry, being in big hospitals like the Mayo Clinic and at the Johns Hopkins, I ended up where I am today, which today I am really happy to be leading multiple global health projects at our program. So, in our program at CIBIT, that's how we call it, our students, we have a cohort every year between 25 to 28 students, and they have two projects. One project is the local project, which is in United States. They have to innovate, they have to find what are the needs, what are the opportunities in the country. That's the local project, which I say it is fantastic, but where my heart is landing and where what I lead is the Global Health Project, which is the second project that our students they have to get extremely involved. So every year we have four different challenges or diseases that they should understand better. Some of those projects they roll over year by year and then they take over from the previous students cohort, and then they keep leveraging on that project, analyzing more the problem, analyzing more what is the need, and even sometimes tweaking what is the technology based on all the feedback that they are receiving. One of the key things about our global health projects is that, which we also do in our local project, is that they have to go every year for a whole month. Students can decide if they cannot for any health issues or their personal needs. They don't have to go, but we highly recommend to go to the field. They have to go to those countries to really understand what is the need, to talk to the community health workers. What are the main issues they are finding when they are providing a TB test? What are the main issues they are finding when they are collecting those mosquitoes? Which Sunny later on, he will explain a little bit more about this project. And one of the projects that we also have is breast cancer. Some time ago, which it was 4 years ago, we challenged our students to go to Uganda and Kenya to understand the landscaping of breast cancer. What was really happening in breast cancer? That we were finding so many women dying or with late diagnosis of breast cancer in Uganda and Kenya. And I will explain a little bit later what is the history about the breast cancer project. I want to touch base really quickly about our CIVIT's spiral innovation model because this is a model, it's not top bench innovation type where the innovation is created in the lab and then we go to the field and we apply that innovation is the other way around. We, first of all, students have to learn about what are the healthcare workers' perspective in country. Otherwise, we don't see there's any value for them to innovate because they really need to personally be there talking and interviewing and co-creating that technology with the main individuals that they are having those needs, those and creating those opportunities in collaboration with the people that is in the ground. And all our global health technologies that we have been creating have been developed like this. And what you can see here on the spiral loop, because we have four quadrants. One is the clinical quadrant, which is what we insist a lot to talk to the community health workers, talk to the technicians, talk to the pathologists. What are the issues that they are finding? And that's what happens, what I was saying, for instance, in August, which is when we start our course. We start between June, July, and then in August, after taking some classes, they would go to the field. Right now, I have four of those teams. One is in Uganda, the other one went to Colombia, uh, and I have the other team in India. And sometimes we can go to Tanzania. This last week, the team that is in Uganda is going to Kenya as well because we need to test in one of the projects the technology. So on the clinical part, that's what they gather. They do interviews, they gather information, they observe, they do a lot of observational to understand what's the patient pathway, what's the technology pathway. The second quadrant, which you can see on the bottom right, is the commercial landscaping. They have to understand in each country, because each country is different, what's the regulatory and the compliance issues that they will need to follow to make sure that that technology that they want to develop will be able to be implemented. And that is something that we all really understand at CIVIT. What you are building in United States or in Spain or in Uganda, it may not be applicable in other countries because it has to adapt to the landscaping of their healthcare system. What we built in Uganda, it may be needed to be tweaked in India. Or the commercial pathway, it may be different. So that's why we also insist since the beginning that they have to have in their minds what's the commercial and the regulatory pathway. After they go to the field and they come back with all these learnings and interviews to main stakeholders, our students, they start doing their design process and their technical process. They start developing. They are really mucky and techy and they are fully hands-on. We have a lab with 3D printing machines, any type of tools, a machine shop, that they can, and all whiteboards, and Dr. Weisbach has been there, that they can. Basically, it's hands-on. It's the time for them to start creating, to start using their hands to develop that technology. What we also say is that if you need to go back to the field to test it, you are able to go back to the field and test your prototypes. Prototype beta, alpha, MVP, they go through all this process. And then at the end, we also want them to have in mind what are going to be other type of issues or challenges that are going to affect that innovation. For instance, financing. Who's going to finance the solution that they are proposing? What type of skills do they need in their team? Because it's a team of between 4 to 5 students, and maybe they don't have an AI person to code and create the AI model. So the students will need to find that AI person. Maybe they don't have an entomologist on their team, like that's what happened to us a couple of years ago. And we partner with our entomologist in country, in Uganda, to help us to develop the tool. So this is something, these four quadrants, and it's called the spiral innovation model or innovation loop. It's because every time that our students are iterating in their technology, they do have to keep in mind the four quadrants in their innovation, in their iterations. What is Changing gears now that I explained to all of you how do we think and how do we innovate at Johns Hopkins. At Johns Hopkins, we have the Global Women's Health Innovation Program. This is led by the Dr. Susan Harvey. She was a radiologist here at Johns Hopkins, but also she created her own company. Really successful company in radiology and identification of breast cancer. And we are following her mindset. She wants to create a one-stop shop to be able to early diagnosis, detect, diagnose, and treat in one single stop, in one single visit. This is something that is going to take us time to get there because there's a lot of technology that we have to validate in the whole process. But this is one of our biggest projects that we have led by her. And at GWIP, that's how we call it, the Global Women's Health Innovation Program, I'm going to share with you some of the projects that are related to women's health. For instance, this is our director, Dr. Susan Harvey. I recommend to all of you, and I can send this link in the chat, to just take a look of their vision. I think it's going to impact not in just in Uganda, in multiple countries as well in our areas in United States, her vision. And this is what I was talking about, the single visit point of care. It's early detection, guided biopsy using AI and ultrasound. One of our projects, we use the FNA. We try to innovate in FNA in Uganda. Then we have a rapid diagnosis that has been developed in one of our labs here in Johns Hopkins. It's like a COVID test. And at the end, the treatment with cryoablation that currently it has been tested in, and it's been also used. And there's actually some cells already in customers in the veterinary sector. So we're trying to bring this veterinary sector to the human sector, which is going to take a little bit longer, we know. But if it works in animals, hopefully we are able to prove that it's going to work in humans. So, some of the projects, and please stop me if anybody has questions. I know I'm on a time crunch, so Professor Weisby, I would ask you if you can keep me on time. When I have 5 minutes left, let me know. But some of the projects that we had at GWIP, we work in multiple countries in these last 15 years that our center was created. We work in Uganda, in Kenya, in Tanzania, in India. And these projects were either brought there to test or created there after finding a need. For instance, Nemo. Nemo is one of my favorite ones. I shouldn't have favorite ones, but I feel really attached to Nemo because it's an early neonatal illness detection. It was co-developed in Uganda, in the healthcare centers, and it was shown, and I have here a slide. It was shown that there are 7 signs that WHO has proved, qualitative signs and quantitative signs, that to understand when a baby needs to go to the doctor immediately for severe issues. Those issues, for instance, difficulty feeding, some convulsions, the chest drops down, your respiratory rate drops minus to 60 BPMs. These signs, our team put all of them together in a tool for mothers in Uganda to detect them. The qualitative signs, they created a video guide tool to understand how to detect the signs and when to detect. It was a video guiding the moms to see those signs. For instance, difficulty feeding, they could see it, but the convulsions, they were teaching the moms. One thing that they learned and we took away from all our interviews are those in doing a usability study is that the mothers provided feedback that instead of doing a notebook explaining to them those signs, they prefer a video guide. And that was one of our changes or that's how our team pivoted to video guide. The other, or audiobook, the other need that we found is that it was a little bit difficult to detect those quantitative signs that you see here on the left side, the temperature and respiratory rate. And the team at Hopkins created a wearable sensor to measure those quantitative signs. This was created in Uganda with the Makerere University, and there's even a patent for, I believe, a patent for this wearable sensor. Let's switch gears, and I see there's a comment. Let me just check the comment. It's not for me. Let's switch gears to the breast cancer. So most of you may know that 1 in 2 women are diagnosed with breast cancer and die from the disease in Uganda and other African countries. I'm checking the messages. And
Don't care about the chat. Just have
okay,
that. You have
perfect.
10 minutes. You have 10
Perfect.
minutes.
10 minutes, good. And 80% of those moms, they do have breast cancer, but they are diagnosed really late on stage 3 and 4. And this is quite late. That's when we found that need, our team in 2022, they found that need, and they learned that between 6 to 11 months it took to diagnose the moms in Uganda. So that is a big issue that we were trying with the Ugandan team. We are trying to solve. How did we get there? We learned that in Uganda there's only access to 18 pathologists, and we also learned that there's some moms that when they are in either in the districts or in the villages, they don't know how to access to those technicians to have the diagnosis of the breast or of the breast cancer. They found there's a lump. They might feel it. They might go to the district, but in the district there's missing some resources to help them detect. In collaboration with the districts, one of them was also in Mayuge, and I think we went also to Busoga region. We learned that we could do a fine needle aspiration in situ and put into what you can see here on the right side into the microscope a lens connected to a smartphone, and the smartphone with a slide and the biopsy of the fine needle aspiration, we could find the cluster and detect the cells, if the cells they were malignant or not. This was our idea. This was our hypothesis. We had a lot of hypotheses. For instance, we wanted to bring this technology in the healthcare level 4. And what we learned, and here is how we started. I gave you a little bit of the background. We started with finding the need. We wanted to decrease the time to diagnosis and to reduce that late stage diagnosis of breast cancer. And where we are today, after 3 years, is we are validating the technology with multiple pathologies and our prototype. And we have learned this last year that maybe our technology will need to pivot. And how did we learn that? First of all, our first year, our team, when they went there between 2022 2023, they created basically what would be the technology. They, after talking and doing multiple interviews and doing a usability study with cytotechnologies and pathologists, they developed what is called today Echalo. Echalo is an AI tool that cluster. I have somebody writing on the screen, Liverson Wabibi, I believe. Thank you for doing those amazing drawings. So we created Echalo, and Echalo with the pathologies. What we said is at the district level, we could get a biopsy, and then with the AI tool find where are the clusters. You can see here, number three, the cluster of malignancy. And when our AI tool detects that malignancy, that would be sent it to our pathologist to get confirmation. Once we get that confirmation, the mother or the woman would be notified, and that mother would be sent either to a regional
Just a moment.
hospital.
I want to ask Levison Wakabi to behave, or else I'll drop you off this session.
Thank you. Perfect. Thank you so much. So we went and tested. Next year, we went and tested in 20, let me do next slide, in the 2024 cohort last year. Last year, this is our cohort. They went to Uganda to test one of our hypotheses. Could this technology work at the district level, at the level 4? And unfortunately, we learned that the incidents or the woman reaching to the level 4 locations were really small, really, really tiny. It was between 3 to 4 women. It is true that we should have spent more time, and maybe we need to find another way to reach to those women. To have that early detection. So that opened up another new hypothesis. But what we learned is that having this technology at the level 4, based on all the feedback, all the key interviews of main stakeholders, for instance, stakeholders from Embarara Hospital, Mulago Hospital, and the district at the district level, they went to 3 different districts. We, based on the feedback that your brothers and sisters share with us, they suggested that instead of having at the district level, we could bring that technology at the regional level. At the regional level, it is true that there's pathologies, but that would be a way to streamline the process and to streamline the time that the pathologists have. For instance, right now, a pathologist may take between 3 to 9 months. This tool could speed up the process and just provide a full list of images for the pathologist to confirm. And that's, I hope you can see the spiral innovation model that we have, that every year our core team would have a new hypothesis to improve the technology. And they would go to the field and do more interviews and have their hypothesis and collect the data. And based on the data, iterate in the technology. Where is today? And this is some of the results I wanted to share. After receiving the team from 12 pathologies and 13 lab technicians feedback, we got a 93% of a specificity of our AI tool and a 95% of detecting malignancy, but that was with preliminary data. When we use field data, our specificity dropped down to 60%, and that is not good specificity, and we need to work more. And that's what the team today, in collaboration with pathologists from Johns Hopkins and from Uganda, they are working to increase the specificity of our AI tool. And what I mean with that is to detect if there's malignant cells or not in those clusters. Other studies that we do when we are in the field are usability studies, and I believe Sunny will also share with you some numbers. In this case, our numbers based on Mulago and Embarara feedback, we got a score, system usability score, which it tells you that technology, how well adopted and how well seen it is for the user. We got a 53 score. It is really poor. It's not a good score. And that means that we need to improve the technology. That means that we need to go back to the field and ask more questions how to improve a shallow.
You have 2 minutes.
Thank you. With the Chalo, we had also other innovations. One of our innovation, it was yield. Yes, we wanted to improve the adequacy of the fine needle aspirations and the biopsies. This was one of our teams that they also go to Uganda. And another idea that we have is do the same, do fine needle aspiration or placement of the needle using ultrasound, which this is one of our areas of innovation that we would like to bring to Uganda again. But we have put it on hold. This is some of our members at Johns Hopkins University under the the GWIP team. There's Dr. Harvey, Dr. Yazzie. Dr. Yazzie is our executive director of CIVIT. Sophia, one of our fellows. Without her, most of our students won't be able to come to Uganda or Kenya. One of our main pathologists, Dr. Van der Bush, but also we have partnered with Mulago Hospital, Embera Hospital, Makerere University, multiple in-country bioengineers, liaisons, and I hope you can get a sense of how at Johns Hopkins we like to innovate. With that said, any questions that some of you may have?
We'll have questions at the end. Members, if you have
Perfect.
questions, please you can put in the chat. But thank you so much, Marina. I think Sunny, if you can load your presentation. What Marina has taken us through is Echalo, you all know Echalo, the village, which is basically, can we find solutions for cancer diagnosis, where they started by doing initial qualitative research, observation, and then thinking about a solution and going ahead with designing the solution. So we are going to hear from another innovation called VectorCam, and over to you, Sunny. You have 20 minutes.
Okay. Well, thank you, everyone. My name is Sunny, calling in from Mayuge, and so I'm gonna see if I disconnected from the call a couple of times. I'm gonna keep my video off to make sure I stay here. But my name is Sunny. I'm in the same program that Marina was speaking about, the Center for Bioengineering Innovation and Design. As following the process that Marina outlined, for the last 3 years, at least a part of my journey, and this project has been continuing since 2020, so it's for 5 years. We've been designing and iterating a digital platform that allows malaria programs to track mosquitoes in real time in an accurate, reliable system. So I will walk everyone here today about the work that we've done here, primarily in Uganda, when it came to designing and development of the technology. What did we do to make sure that we are confident that the technology works? How we conducted a randomized control trial in Mayuge and Adjumani districts alongside the National Malaria Elimination Division. And then what is our next steps? How are we thinking about scaling VectorCam in Uganda? And so, as some of you might see from the side, is VectorCam is empowering health workers, and in Uganda, it's the village health teams using our AI-powered vector tools, and we provide real-time dashboards to close the surveillance gap, specifically for mosquitoes. So I'm going to start with some high-level information so everyone is more aware of what the problem this is tackling. Not to speak too much about this, but as everyone on this call knows, a child dies of malaria every minute. Professor Weiswa and I always speak about how Professor Weiswa always loves to mention that malaria itself is such a strong connection to maternal and child health that this disease itself has such a graph on how much is affecting maternal and child health, and that mosquitoes themselves are the root cause of why malaria spread. Mosquitoes are known as the deadliest animal on Earth. Still, 83 countries are endemic because of malaria, and many conversations I have had with ministries of health across Africa, malaria is still the #1 concern for many of these programs. And on top of that, these mosquitoes that are spreading malaria cases from person to person, we've learned from the communities, it is a community disease. I've heard from many different social behavior community programs that having one person sick and that one person not doing their diligence to protect themselves is the reason malaria is spreading from person to person. So it's really a community effort. It's not an individual fight when it comes to fighting mosquito-borne diseases. Also wanted to highlight that malaria itself falls into a category called vector-borne diseases. Vector-borne diseases are spread from mosquitoes, but they're also spread by other insects such as ticks, snails, sandflies, many different diseases that are still being heavily studied today. And globally, a lot of people are now having a conversation that the mosquitoes that are spreading malaria, which is the Anopheles mosquito, there's another mosquito that's causing a lot of concern globally, which is the Aedes mosquito. And now there's record cases of dengue fever across South Asia, South America, and now everyone is concerned that now that we're going to have multiple different mosquito diseases all combined at the same time. And so there's a lot of warnings that are being sent out due to climate change. These mosquitoes are adapting their behavior and they're able to actually spread really quickly. And so to speak about malaria outbreaks in Uganda, as Marina mentioned, that these outbreaks we've seen that because there's been a lot of effort against malaria, such as distribution of bed nets, indoor residual spraying, there's a lot of periods of times where clinics will actually have a lot of downtime. So they'll operate as usual, but unexpectedly, there will be a huge outbreak of malaria that happens, which causes a lot of clinics who have a stable amount of resources to actually go under firefighting. And so that now you're handling all the influx of patients that are coming in, and you are kind of in the firefighting mode of fixing what is happening on the day-to-day, and you can't focus on long-term strategies, which is understanding why did this outbreak come in the first place? Why are the mosquitoes spreading the disease when they didn't spread the disease before? Because you're in this mindset, I need to protect as many children and mothers as possible. And the reason behind this is that there's a critical gap. And like Professor Weisswa mentioned, that how do you turn problems into opportunities? That vector control, and when it comes to decision making about what we should be doing to control and eliminate the mosquitoes, there's not enough mosquito experts who are able to identify which mosquitoes in the communities are spreading diseases. To understand this system, large public health programs or implementers, so you could think Ministry of Health, and implementing partners such as the WHO, you could think of JAPIGO, Malaria Consortium, many different implementing partners. What they'll do is they'll do campaigns for bed nets, they'll do campaigns for indoor residual spraying, and then this is a very, as many stakeholders have told us, this comes and goes in various frequencies. And so already it is a fragmented system. Some parts of the country will receive the intervention first, then other parts of the country will receive different amounts of bed nets later. And the community has no idea what is happening because a lot of this information is coming down from the national policy level down to the community. And then once these public health implementers are sending out all of these ways to control for the disease, they need to do a system called vector surveillance. And what vector surveillance is when you distribute bed nets, the underlying assumption is that the Anopheles mosquito that you are controlling for with these interventions should go down. And many times, many districts don't have the capacity to understand and track the mosquitoes. So things such as which mosquitoes are in my community, if there's a lot of female or males in my community, and both actually tell you interesting insights about environmental factors, and whether those mosquitoes are actually biting humans in the hut that these bed nets are going to. And so that system is also very slow. So you see something that's very slow and fragmented when it goes out to the communities, and then the information coming back from the communities is very slow. So the cycle ends up being like a very months to years process before people who have the decision ability are able to understand what's happening at the community. And so through conversations with vector control officers in Uganda, the National Malaria Program, as well as public health systems researchers, the idea here is how do we make a rapid mosquito collection system? There's a lot of experts in Uganda, but there's not enough to go around. So how do we design a system where community health workers are able to rapidly collect mosquitoes so that public health implementing bodies are able to react much faster and understand if things such as climate change, insecticide resistance, new species that are entering from various ports or borders are influencing how malaria outbreaks are happening to catch them faster. And so to introduce what the opportunity that arrived is we developed a technology called VectorCam, an AI-powered smartphone technology to help health workers identify mosquitoes instantly. So the picture you are seeing on the left is a device that we 3D print. So the cost of manufacturing is low, and we're able to customize it to the needs of the community. And then on the right-hand side is actually 4 village health teams in Makerere using the device to rapidly take pictures of mosquitoes and then use our platform to upload all this information to a digital platform where ministries of health and local district vector control officers can look at the data and respond. To explain what is VectorCam, VectorCam is actually a 3-part process. You have the 3D printed hardware that I mentioned, paired with a user-centric Android app. Then we have an offline-ready algorithm that sits inside the app itself. So these 3 different parts is what makes the accessible field tool known as VectorCam. And I will explain each of these individually and how these parts come together. But in order to demonstrate and make sure our partners understand what is the technicalities and what is the performance benchmark, we actually published 2 papers, one on the AI's algorithm and another on a usability study that was conducted with the tool itself. So one, I could speak about the AI model. A lot of things are being said in the news, in many different innovations about we're using deep learning and we're using artificial intelligence. So to explain a lot of different innovations and maybe pictures you've seen, what powers a lot of these deep learning models that could detect different things is called a convolutional neural network. What this convolutional neural network is think of it as your human eyes. When your human eye is able, when you're a child, you're able to differentiate what is a dog because you see hundreds of pictures of dogs. And what is a cat is because you see hundreds of pictures of cat. And the way your brain processes it through all your neurons, we don't know what's happening inside the brain, but we know after looking at lots of dogs and lots of cats, a child is able to separate out which is a dog and which is a cat. These convolutional neural networks follow the same principles that you show them lots of data of what you want to identify. And by the end, after running lots of mathematical calculations, it's able to tell you what you're exactly looking at. Except the challenge in 2025 globally is that because this is millions and billions of calculations that are happening in a matter of seconds, we are still as a society not able to understand what is happening on the inside of this machine. We know what we feed it in the beginning, and at the end, we're able to see that it's able to tell us an answer. And so this is used in a lot of like autonomous cars. It's used for facial recognition. And for our technology, we're using it actually to identify the different species of mosquitoes. And so working with vector control officers for 2.5 years to get started, we collected thousands of data points across the primary culprits of malaria, which is these main vectors, Anopheles phonesis, Anopheles gambiae, and a heterogeneous class called Anopheles other. We fed this convolutional neural network with tens of thousands of pictures until it finally understands patterns that tell you the difference between phonesis and gambiae. And the reason you want to know the difference between these two is that a lot of these different malaria biters, some of them will bite you inside, some of them will bite you outside, some of them will bite you during dusk to dawn, the 6 p.m. to 6 a.m. window, and that's why bed nets work so well. But some of them will bite you during the day outside. The challenge is a lot of times these global circles will think that one solution will kill all the mosquitoes. That is not true. You need to have a very custom fit solution for every community because what's happening in Makerere might be different than what's happening in Iganga, which might be different than what's happening in Jinja. What you need to do is have a good surveillance system. And so on the right side is a confusion matrix. This confusion matrix is how a lot of AI models are graded about how well is the performance. And so as you could see, that diagonal is very blue, which means the accuracy was really well. This is when we were testing images out on a controlled environment in Uganda, which means on a phone itself used by entomologists. Except the challenge is, how do we make this into a field tool? And so some of the factors that we had to consider was high accuracy, being able to operate without the internet, easy to use, and a lot of other factors that would make it scalable in Africa. And so similar to a lot of the other innovations, we went through many different designs, talked to the vector control officers, talked to the VHTs, did 16 design iterations to finally land on the device that is being currently used in Uganda. And between August 2023 and August 2024, a next step of ours is that this tool worked in a controlled setting by entomologists. We wanted to demonstrate for the first time how this tool can now be used by community health workers in a digitalized reporting system. And so in Mayuga and Ajumani, we conducted a study arm and a control arm to show in the study arm, if VHTs are given the device, how well are they using the device? How accurate is the model performing in their hands? And how fast is data now coming into the system? So on the left-hand side, you'll see is that the images are being taken, and within minutes, you're seeing the species, the sex, and the abdomen status or the feeding status of the mosquito populating on the screen within seconds. So a worker is able to click picture and move from mosquito to mosquito rapidly. Wanted to highlight that at the end of the study, we were able to find that our village health teams did have errors when it came to imaging mosquitoes at a very minimal rate. And so of the 73,000 pictures that they took, 8% of which were actually filled with mislabeled specimens, or they had mosquitoes that had missing body parts and missing wings. And so overall, the performance of VectorCam did very well. Across the classes that the malaria program wanted to see, village health teams were actually capturing and identifying mosquitoes at a sensitivity and specificity that matched or outperformed some entomologists, which included a lot of junior entomologists positioned at different districts. Another factor that was very important for malaria programs is how complete and timely is the data. And so the malaria program has a mandate for all districts by the 15th of the month, the data must be uploaded. So by day 8, VectorCam was actually able to upload 100% of the data. The reason it took 8 days is because all the information is happening in the field, in the village, and then that phone just needs to connect to the internet. When it connects to the internet, all the data is being uploaded into the digital side. Versus on the control arm, we found that only half the data is making it by that day 14, day 15 date that the ministry has asked for, so that they could start making decisions about what is happening. And then the throughput of it is that the VHTs were going through mosquitoes at the same pace as the field entomologists were, showing that this task shifted system is a reliable system as they are moving just as quickly. Kind of turning towards the end, we populated all this information. Right now, all this data sits in DHIS2, which is a very health informatics Excel sheet. And so you see a lot of cells, you see a lot of rows, but it doesn't give you the insights and the patterns that you want to look for. And so as an initiative, we built out a dashboard with a lot of feedback to say, what are the most important facts that we should present on this board? And something to note is that in Ajumani, there was an indoor residual spraying campaign done. And so after that was done at the end of December, we actually saw a drastic drop of IRS from the remaining of the RCT. Oftentimes, programs will use IRS systems, but won't have the reliability to keep monitoring it. And this is just another graphic to see.
We have 2 minutes, Sunny. Thank you.
Thank you. And these are just more a lot of this surveillance systems is understanding patterns. And you want to see the patterns in real time. And when you're doing interventions such as indoor residual spraying, handing out LINs, how are the mosquito vector populations changing? And as Marina mentioned, we did a system usability scale questionnaire with the VHTs. And so prior to the RCT, we were benchmarked at the 50th percentile on this score, which is a 10-question questionnaire that asks you questions such as if you feel confident using the system, if you like to use the system frequently. And after 1 year use and all the changes that we made to the system, we actually jumped from the 50th percentile to the 90th percentile, giving us confidence that A, it takes time, and B, a lot of the changes we made, people were appreciating and using in the next run. Just kind of concluding what is our next phase, we are actually observing factors that will make implementation succeed and fail as we are preparing for a national rollout in Uganda. As with a partnership with the National Malaria Elimination Division, we're creating implementation strategies with the Ministry of Health to maximize the success. And now we're going to see what it takes to go from 2 districts to 14 districts. Ministry of Health to use locally found phones and putting the app on it, and then developing the trainer guide for global dissemination. And this is where I'll end my presentation. There's a lot more reach now in order to become a scalable, sustainable operation. we must make the cost very affordable, which means manufacturing in Africa and allowing for a lot of different studies to happen to show that this technology works at the national level, it works for researchers, it includes a lot of species. How do we actually empower the health workers who are using the data by turning the data into actionable insights? A lot of data is gathered in many different fields, but now how can we use modern tools to rapidly act on it? And the last point is a lot of strategic support is still needed as we're growing from a research lab into a proper NGO initiative that will do this globally, not only across Africa, but our vision is to do this across the world. How do we scale this up properly where everyone is not being pushed too thin? There's not too many different countries everywhere. And the solution is polished and always professional when it's handed to an individual. And so a big thing for us is being community owned and sustainable. And so, Dr. Weiswell, I will finish here, but this was the overall idea about how we took a product from just a concept to now we're doing a national pilot in Uganda.
Thank you so much, Sane. So I'll just summarize this for the listeners. What we wanted to see in this webinar, how we turn all the time we are having problems, but can we turn these problems into solutions? Marina presented HRO. Basically, the initial idea was many patients with cancer are diagnosed so late at stage 3 or stage 4. And that was the initial observation. And they did research and observations and eventually came up with an idea. And now that idea is a question, how about if we can take the samples using a simple needle, but also be able to make a slide from anywhere, like a health center 4, and digitalize that slide and then send it maybe to a pathologist to read, or even the AI could read. So that is basically an idea which they had, but there is no way they could do it alone from Hopkins. They had to come down to the field. And then we have a lot of malaria, and we need to know the types of mosquitoes. Usually we use vector control officers or entomologists, but we have only one entomologist per district. So the question was, how about if we use AI, an AI-powered tool to identify these mosquitoes? And what we find in work done in Mayuge, and right now Sunny is in Mayuge, is that just in 20 seconds, an AI tool, basically you could say developed in Uganda, in Uganda here, can actually identify mosquitoes in a very short time, and can do it better than even an entomologist. And this tool, Bill Gates spoke about it. I've shared a YouTube with you members. You can look at it. And it's going to be rolled out to more than 10 countries around the world, but maybe more. So I have to, and our PhDs are the one using the VectorCam tool, and our health workers at Health Center 4, if we succeed with the Charlo, are the ones who will be really using the AI-powered tool for cancer diagnosis. So I have 2 questions, then I'll invite the members to ask some questions. So for both Sane and Marina, what advice how would do these health workers who are not trained in making technology, but all the time they are having problems, they are observing, and how could they turn some of these problems into opportunities? So that is one question. Number 2, could you speak a little bit about the commercial value of the product that you've presented? Can these things become go to the market and become a business? And is this a new way to train people in universities? So I think those are the 3 questions, the 2 questions I wanted to ask. And there was also one question in the chat, which somebody is asking, how shall we translate these? How shall we translate these findings to benefit communities? So maybe you can answer whichever question you're comfortable with. And members, if you have a question, either put it in the chat. If you have a question, either put it in the chat or or if you put it in the chat or put up your hand. Sane and Marina.
Professor Weisbach, let's see if at some point you got cut off. So let me see. The two questions you are asking. How do we turn problems into solutions? And the second one is going to market and creating a business. How people at the university how are we basically creating those new businesses and spinning out or spinning off from the university? Is that correct?
Yeah.
Perfect. I'll take the second one and a little bit of the first one. Sunny, if you don't mind. How do we turn problems into solutions? So we have a full process of observing the healthcare system. So that's why our students they go to the field. And when they are observing, they are doing interviews as well, and they are asking those open questions to understand the pathway of some procedures. In the case of breast cancer, when our students they went there, they did a full at the beginning. What we did is a full landscaping of the breast cancer in Uganda and Kenya. And what we learned is that there was an issue that it was really late. They were diagnosing breast cancer really late on stage 3 and 4. So when the students found that gap, and when there's a gap, there's an opportunity, they turn that into how can we help and how we can partner with the people in the field to close the gap in the system, basically. And that's how we turn those problems into solutions. Basically, we find what is the need. They have to really understand what's the need. For instance, they have to go and ask multiple stakeholders and multiple links of the healthcare system and people involved. What is the process? When they understand the process, they find what is the need. And when you have a need, then you develop and create the solution or your technology. Sometimes the need, it might not be solved just within an AI tool or a Nemo, a wearable device. Sometimes it's a bigger challenge, is a healthcare system challenge that there's not enough pathologists. So we need to become really creative on if there's not enough pathologists in country, how we can help the pathologists. And sometimes pathologists will tell you, I will need more help, I will need to streamline the process. And that's why you start iterating based on all these feedback and collaborating with the pathologists, you create the solutions. That's the first one the question that you asked, Dr. Weisbach. Sunny, do you want to jump in?
I could speak about the VectorCam project, turning problems into solutions. One thing I didn't mention is that this problem originated actually in 2017, 2018 in Brazil during the Zika epidemic, where it was trying to stop and understand dengue's and Zika spread in Brazil. But then with the help of a lot of control officers and field entomologists, of which actually one has joined this call, Chigongo Siriman. I wanted to say thank you for joining. But through them, we were able to understand where is the real bottleneck and understanding the value. So for them, the value was how do you make preventative malaria measures happen at the community level? And they felt that of all the tools given out today, vector surveillance is a process that was very much on the bottom side of the resource portfolio. And they said that a system where community health workers can be inspired and empowered to do this would go the distance. And so we created a bunch of concepts with them. And it's through working with professionals and experts who know the field in and out, that's how we were able to create a solution that mattered. And what Marina said is that VectorCam was the start. We actually have 4 more tools that we're working on that are targeting so many different aspects of the problem. So nothing's ever going to be a one solution fix.
And can
Thank
I
you
ask
so
a
much.
little bit? Can I get a little
Okay.
vector cam? Um, Sunny and I, and actually I spent a whole